welcome. I am Sabrina Darrington. I'm the Director of Research Ethics for the Southern California Clinical Translational Science Institute and the Director of the Center for Bioethics at Children's Hospital Los Angeles. And this is our Research Ethics Forum, which is an educational event and an opportunity for everyone involved in our research community to dig in a little bit to ethical issues in research. And I am very excited today to introduce Dr. Alyssa Burgart, who is joining us from the Stanford Center for Biomedical Ethics. We're just really excited to have her talking with us today about artificial intelligence and machine learning in research and how we think about ethical frameworks for its use. Dr. Burgart is a very skilled and experienced pediatric anesthesiologist, and she's also an incredible bioethicist and has written and teaches widely on a number of ethical issues and topics, both in the pediatric ethics space and more broadly. She's very active on social media and has a whole sort of career and effort directed there at increasing awareness and advocacy around really important ethical issues. And she leads clinical ethics consultation services at both Lucille Packard Children's Hospital and at Stanford. So we're just really so grateful to have you with us today, and I'll turn it over to you.
Thanks so much. I'm so appreciative for the offer, and I love talking about kids. I love talking about research issues related to kids, and AI, I think a lot of folks are really intimidated by it, and so I'm really hoping that this meets the needs of folks who are sort of just entering this journey of thinking about AI and thinking about its role in research, and hoping that that's something that can help folks to feel a little bit more equipped to think about these ethical issues and to just explore what this means for our shared work. So I'm delighted today to talk about Accept AI, encoding ethical values in AI and ML research. And I'll be excited to hear what all of you have to say. Oh, and in the chat, I just dropped a link, which is where all of the resources for this talk are present. So please feel free to click that, and you'll have easy links to all of this content. So for disclosures, I have no financial conflicts of interest. I will tell you, I am not a tech person. I'm not a Luddite. I tend to be sort of an early adopter of a number of technological things that are going on. I tend to be quite curious about them. And living in the Bay Area, there's certainly a lot of opportunities there. All the images I made for this, I used using DALL-E, which is the kind of image generating software that is related to OpenAI's platforms. I always find it super funny. If you tell it exactly what to say, it will still misspell everything. It'll be interesting to see how that changes again over time as these systems develop. In terms of sort of an activation, a care warning, I am going to discuss serious harm to children, including sexual abuse. If that's something that you are not game to hear about today, it will not hurt my feelings if you need to take a step away from this lecture. I hope you'll do what you need for yourself. The goals that we'll talk about today, I want to make sure that you're able to really recognize pediatric algorithmic bias as a unique risk to children. Certainly, this is something that will, I hope, influence your thinking around other types of algorithmic bias. And then understanding the generational impact of using pediatric data in these algorithms and the ways that excluding children's data, while sometimes seen as an alternative, can also have generational impacts. And then thinking about how the data that's included or excluded in these training algorithms can meaningfully impact end users. And so how is it that research that's being done today may impact users, whether they know anything about that research or not? And so when I think about the ways that something might impact children, which is the population that I tend to be the most attached to, there are lots and lots of things that we know impact children. So their access to education, the quality of the education, the physical environment, environmental issues related to things like pollution, what sort of health access do they have, things like ACEs, adverse childhood events versus positive childhood events, and then things like toxic stress. And so I say that to sort of then lead us into this concept around moral outsourcing when we think about AI and ML platforms. And Ruman Chaudhry talks about moral outsourcing and really coined this term. And she defined moral outsourcing as the anthropomorphizing of AI to shift the blame of negative consequences from humans to the algorithm. So for example, she notes, you wouldn't say my racist toaster or my sexist laptop. And yet this is exactly how we talk about the algorithm. Even if we actually are talking about many different algorithms, all of these are things that were designed and deeply influenced by human beings who created them. And so when we anthropomorphize these algorithms, it really takes that pressure off of the people who have actually been producing those products. So again, I just want you to take this forward with you, this idea of moral outsourcing. And when we think about this quote from Hannah Arendt, she said, the sad truth is that most evil is done by people who never make up their minds to be good or evil. And one of the things this was commenting on was, for example, in Nazi Germany, where you might have somebody who said, well, I wasn't a bad person. I was just a truck driver. I was just doing my job, driving trucks of people back and forth to being slaughtered. And so thinking through our history about how it is that we connect moral outsourcing that's happening today versus what moral outsourcing may look like in other contexts. The coded gaze is another really wonderful phrase that I think can really help us to think about the ways that bias impacts algorithmic outputs. And so Joy Buolamwini, this is a picture of the cover of her book, Unmasking AI, which is a fabulous book if you're interested in learning more about this. She talks about the coded gaze as the embedded views, again, these human beings who have made algorithms, and how those views of those people are then propagated by those who have the power to code those systems. And so whether you read her book or not, she's got a bunch of fabulous videos as well. The reason she's holding this white mask is because as a dark-skinned person, she found that trying to use early facial recognition software early in her training, it could not recognize her face because all of the faces that had been used to train this data set, this algorithm, were all of light-skinned people. And so it was in fact by wearing a white mask that she was able to be recognized by this facial recognition software. And so when we're thinking about things like AI and things like ML, these are learning systems, and that means that they're going to be influenced by a number of factors. So again, the data, the accuracy and integrity of data, the amplification of that data through its consistent multiplication. You can also diminish certain data. Additionally, you can think about what are the populations where something is applicable. Again, I'm thinking about this from the perspective of children. And then the idea of unlearning. What are sort of the opposite of amplification? Rather than straight diminishment, how can we unlearn things in a system rather than simply having systems learn all of the information that is put in indiscriminately of its value, of its accuracy, and of its integrity. As somebody who, again, is like fairly early on my sort of understanding of AI, again, I'm not a tech person. And so I'm really hoping for those of you who are in the same boat, who are maybe just a few years behind me in your understanding of these, I hope to help you understand that there are lots of different kinds of data sets. They're not all the same, different kinds of data sets, just like in other types of research. In AI and ML, there are going to be different kinds of data sets. And so this variety really impacts what kind of outputs such data sets might be used to create. So for example, there are custom human-generated data sets, so where human beings are choosing which data to include or exclude from a particular training set. There's also custom machine-generated data sets, determining, again, what sort of a process will be used to generate what data is included or not included. Natural language processing data. So when you think of it, for example, about using OpenAI's software, for example, to write a paragraph for you or to provide some sort of other language output, those are natural language processing. There are open data sets, there are public data sets, there are audio data sets, there are custom image data sets, there are healthcare data sets. Now, some of these are going to be public, some of them are going to be private, some of them will be proprietary if they're with certain companies. And so these can all influence as well how that data is utilized in research and whether or not we're able to sort of understand what is included in those data sets versus not included in those data sets. And so I want to introduce this concept of pediatric algorithmic bias, because in many ways, we're really not talking enough about the bias that children both are experiencing now as AI and ML is emerging, but the future impacts of children either being included or excluded from data sets that are being utilized at this time. And so algorithmic bias generally is a systematic and repeatable errors in a computer system that are going to create unfair outcomes. So if you arbitrarily privilege one group of users over others, so if we think about Joy Buolamwini's face not being recognizable because the privilege of white faces having been used to train that system meant that she was unfairly excluded from it functioning for her, as well as other patients and other people who have dark skin versus light skin. So that's an example of algorithmic bias, that coded gaze. And so when we prioritize adult data over children's data, or in fact ignore the existence of children altogether when we are creating data sets and training those data sets into algorithms, then that's going to overlap with things like also coded ableism, for example. So if we always prioritize typically developing children over children who have developmental differences, we will not necessarily have a data set that is both highly accurate and has high integrity, and may in fact perpetuate bias specifically amongst children. And so things that additionally can influence the development of pediatric algorithmic bias will be things like incomplete data sets. Again, data sets that don't include children, but may be used to create ideas around children and their health data. You may have unlabeled data, so data that has been included in a data set, but it is not specific what the age is of that person's data. So if you imagine, for example, chest x-ray data, if you don't know how old the patient is who had that x-ray done, then it would be very confusing potentially to try to make systematic outputs about adult versus pediatric x-rays. You may have indiscriminate data. You may have data sets that are explicitly biased towards a particular population. There's an issue of applying adult data to children, and I'll talk about that in more detail, as well as applying specific pediatric data too broadly. So if you have pediatric data on a very unique population, you cannot necessarily then apply that information to a broad array of children. And so age data is an important component of data collection when we think about creating data sets that will be utilized for artificial intelligence and machine learning. So oftentimes we see a lack of reporting of age data in data sets. There may be a lack of children's representation and young people entirely, so we may not be including them. We may not be including information about developmentally important milestones, as well as, again, inappropriate generalization made about a PEDS population from adult data, and the reverse, inappropriate generalizations made to adult populations based on pediatric data. So if you've included pediatric data inappropriately in a data set, you may be creating outputs that are not actually applicable to an adult population. So why is this important for children's health and safety? And I attended a lecture through my anesthesiology department just a few weeks ago where the speaker was showing, it was a whole song and dance about how amazing these language models are, and was showing how, you can show the AI image processing data, a picture of an anesthesia machine and of a patient's vital signs. This is all de-identified, could show that. And then this natural language processing tool would put out a bunch of information and would try to tell you whether the information in those vital signs was within normal limits or not within normal limits. And as a pediatric anesthesiologist, it was so fascinating because while the vital signs that were being shown, and there's no patient in here, so we don't know how old the patient is whose vital sign pictures were being examined. But the reality is that those were very safe vital signs for an adult, but they would have been very abnormal vital signs for a baby. And as somebody who uses the exact same equipment, the exact same monitors, but to monitor a very different population, it was really obvious to see how the assumption that was made that the patient was an adult would have been potentially catastrophic if someone didn't understand how that advice actually was incorrect based on age. So just a real brief example there. This is a really interesting white paper that came out last year, and it's called The Use of Artificial Intelligence in Radiology. Radiology has a lot of really interesting research going on around AI, recognizing that this is going to profoundly impact the field. So impact on pediatric papers. And what they did is they looked at the various types of software and FDA-cleared devices or data sets that were available, and they said of the 200 AI software as a medical device cleared by the FDA, unfortunately, only 6, which was 3%, indicate that they were intended specifically for pediatric use, whereas many of them were absent. They didn't tell us whether they could be used for children or not. And then it said, to date, there are no computer-aided detection, computer-assisted triage, and notification software or computer-aided diagnosis radiology products authorized for use in pediatric cases. And so it's relevant to say the industry that is working on AI and ML software related to radiology and the health researchers who are participating in that research have really not caught up with the amount of data that's available for adults. And then exploring artificial intelligence in pediatric echocardiography. This is a really great example where these these researchers, what they did is they actually looked at AI software that had been developed to look at adult echocardiography that had a very high level of functionality, high accuracy, was deemed to have outputs that were quite reliable. But if they applied that to children, they found that there was significant discordance. And so by taking a program that was very effective when it was utilized in the population, adults for whom it was designed, it was very effective. And unfortunately, when they used it in kids, they found that they took physicians who were examining pediatric echocardiography, and then they compared it to what the AI device outputs were, and they found that there were some agreements. So the measurement of the aortic annulus and the E wave was accurately measured for all ages. So that would be that particular measurement was appropriate. They did find that for patients who were over 9 years of age, they could measure the STJ and the EF, but that was not true for patients who were younger, who had smaller hearts. And then other measurements, they had some good agreement amongst physicians, but the AI did not have broad agreement. So you had a panel of physicians who were gathering the same, coming up with the same results, but the AI was coming up with quite different results. And then oftentimes there was simply poor agreement. Another example where there's potential risk for harm was the Tessa, which was a mental health chatbot. And this was launched through the NEDA, which was all about nutrition. And unfortunately, what happened is some changes were made on the back end to this product that ended up actually recommending weight loss to people who clearly were giving the indication that they had eating disorders. And so it was found to be quite dangerous, and it was very abruptly pulled off of the NEDA website. And so I'm now going to shift gears a little bit further into the ways that child sexual abuse materials can appear in these data sets, and why it is that we need to think critically about our research data sets and whether or not they can be used for nefarious purposes. And so the Lion 5B2 data set, this actually was something that was older models of this data set had been manually labeled. So each of the images that had been included would have been manually labeled and put into this data set that could be used as a public data set that can be used to train different algorithms. And eventually, though, more recent models were actually trained on billions of scraped images that were not actually looked at by any people. Nobody was going through and deciding whether these images should be included or should not be included. And so essentially the data set ultimately ended up being fed completely unguided crawling, which meant that it included a lot of dangerous explicit material, including child sexual abuse material that was then scraped and put into this data set. And so there's a group here at Stanford that's called the Stanford Internet Observatory that identified hundreds of images that were already known. They worked very closely with two different organizations that work to prevent child sexual abuse. So these were images that were known to be history of patient and child sexual abuse material that unfortunately were then being used as by a popular AI text to image generation model. So this data set was actually pulled very abruptly because of the findings of the SIO. And so this is really a huge nightmare, not only for child sexual abuse victims and survivors. So, and to put it in context, what this means is that images that are known to be harmful, known to be child sexual abuse material, were then being used to actually make new images of abuse that had not happened. And so because of the way that child sexual abuse material works, oftentimes victims are notified when their images are found. And so when these are digitally being distributed further, it can actually cause significant re-traumatization of patients because these images are very popular. And so amongst a very specific population. The other way that we see this as a problem is in sexual assault and sexual abuse cases, whether they're pediatric or not pediatric, because we know that revenge porn is another thing that is very much fueled by access to images like these. And so I have links in my resources to both of these really incredible reports that the SIO put out, one related to identifying and eliminating CSAM in training data models, and then another one related to generative ML and how to mitigate that. And so one of the things I like about both of these reports is that I felt as a non-tech person that I could understand. It was really, they've done a great job writing these in ways that are quite understandable for an audience that does not have their expertise. So in their recommendations in the report, they really helped me understand kind of how complicated it is once you have an image that is in one of these data sets, what can be done about it. And so there's a few things that are potentially on the easier side, removing the original hosting URL. So if that image is no longer available on the internet from that site, then that's a way to remove that information. Removing metadata entries in the LION data sets, and metadata is data that is sort of attached to the image that can be used to categorize data, for example. Removing the actual image from the internal LION reference data sets, and then removal of images and references in downloaded copies of the image set. And so unfortunately, it's an open data set. So unless you are successfully able to reach every single researcher who has access to these and who has downloaded them, it is quite difficult to remove that. And then removing them from the models themselves is, again, a very challenging thing because they've already been put in to these data sets. It's already been used to train these models. And so untraining the models from this information can be quite challenging. So ethical AI, and this is something that a lot of folks want to figure out. Is there a way for us to use AI that, I mean, in my opinion, the cat's out of the bag. AI is not going anywhere anytime soon. And so what is it that we can do to really think about the risk of algorithmic bias, the risk of harm that can come to people in our society, particularly vulnerable groups like children? Because these are not just technical issues, these are really some moral imperative for our society. And so this was a framework that was put out by a number of ethicists in a viewpoint, an overarching framework for the ethics of artificial intelligence in pediatrics. And they use a set of questions that was traditionally used to think about research. Is it true? Is it good? And is it wise? And so they say, okay, is it true? So this is a question that refers to whether the outputs of these AI-based technologies, are they trustworthy? Are they accurate? Are they reproducible? Are they true? Is it good? This refers to whether AI-based technologies, are they improving healthcare delivery? Are they benefiting patients, families, clinicians, and/or public health? And then how can we establish a process for wise decision-making? Which as an ethicist, a lot of people think that what we do is very wishy-washy, right? Like, how do you know if something's good or bad? Which, of course, for those of us who spend our careers thinking about these questions, folks who are building code want something that's more practical and actionable. And so I would invite folks to start really shifting this concept of ethical AI to more of this idea of how is it that we operationalize our ethical values? If we want accountable, equitable systems, we have to decide what those features are and ensure that those are included from the ground up. And so based on this idea, my colleagues and I came up with something that we've called the Accept AI framework. And our goal is really to say, how is it that we can take things that we already know about pediatric ethics related to pediatric research ethics, for example, and how can we actually ensure that those are incorporated from the beginning? How can we ensure that we make it easier access for folks who are developing these products and developing these research projects to be able to incorporate these from the beginning? And so in our paper, we really got into the various details of how one way that we could approach these issues. And so pediatric characteristics, if you are in society, you likely have seen that a baby does not look the same as an adult. You walk around your life in Los Angeles and you occasionally will see babies and children, and you'll have sort of a general idea that those are not adults. There are physiologic and anatomic differences that children have from adults. And there's heterogeneity. So like developmental stages within a pediatric population are not going to be universal. Not every patient is going to go through a particular developmental stage at exactly the same age as another patient. And then particularly relevant for our purposes here today, kids are a protected research population. We recognize that they have unique vulnerabilities that need to be addressed. And we recognize that there's unique ethical considerations at various developmental stages. So as a pediatric clinical bioethicist, I think oftentimes about, when we're talking about assent versus consent, how is it that we include patients of different ages in ways that are developmentally appropriate? And so age is really the first thing in our Accept AI framework. Age is the first issue. So when you're deciding on whether it's study enrollment or deciding what data to include in a data set, how can a patient's chronological age in a health data set be included at the time of study enrollment? How can we ensure that a patient's developmental age is somehow codified in that information when that's appropriate? And then how is it that we can make sure that we are thinking about things like height and weight percentile, things that are going to influence, for example, those radiology data sets that desperately need more information on kids? How can we really capture the heterogeneity of a pediatric population? Communication. So how is it that we're going to also, not only do we need to think about the safety, veracity, the accuracy of the output of this potential research, but we also have to ensure that we know how to communicate about this research for people who are both study participants as well as people like yourselves who are doing research ethics work. We actually need to be able to have a basic understanding of how AI and ML works and how it is that it influences research ethics, because we need to be able to assess whether a study is creating communication that will be effective for the population. And so we need to be able to talk with stakeholders, including children and young adult people and their parents, to be able to understand what is the relevant information that somebody would need to have and would like to have in order to make a decision. And speaking of decisions, we of course like to think about consent and assent. And so how is it that researchers who are doing AI and ML research, how are they going to record the mode of consent, who provided consent? Because that you can see when we think about how difficult it is to remove data once it has been utilized. If we think about that list from sort of easiest to hardest from the results of the SIO work, we need to make sure people understand if you're consenting to have an image or certain data about yourself included in this data set, it's not the same as being able to withdraw from a different kind of study. And so how is it that we're going to take those things into account and mitigate those concerns to the greatest degree possible? And so that means that we need to be able to actually have these conversations more effectively. The other thing related to both kind of technology and age and development is that the reality is that if you have an older teen patient and a young adult patient, they are actually probably more likely to understand some of these risks than perhaps their parents. And so also thinking about sort of when we think about the stakeholders who are involved, how are we doing what we can to ensure that we are including the right folks in these conversations so we can understand their needs and ensure those needs are met? And additionally, when we're thinking about, again, the durability of this information once it's included, the consent process would also need to include, will this data ever be destroyed? Will it be removed from the training data set at some point? What will the long-term durability of that information be? And then, consent and assent can be really complicated. Whether or not when you're in research, you oftentimes don't end up including, for example, patients who might be in state custody or in complicated legal guardianship. But we do need to keep in mind, if we are going to include those patients or exclude those patients, that's a choice that we're very clear about when we're helping to design and review studies like this. Equity. So ensuring, again, we've talked about the coded gaze, we've talked about this pediatric algorithmic bias. What are we doing to ensure that the inclusion and exclusion criteria are specifying the population that we're hoping to serve? And so how can we ensure that developmental stages, when appropriate, are included? Are we excluding patients who should be included? Are we ensuring that the recruitment for these studies is going to promote equity, and in what ways will we do that? How can we reduce selection bias? And so how can we be transparent about the reporting on this information, including things like race, sex, gender, socioeconomic factors when appropriate? So really thinking down the line of what data should or should not be included in order to promote equity, and how does that interrelate with things like communication, consent, and assent? Protection of data and privacy is a very significant issue. For those of you who are working in a research, whether it's in a research compliance setting or you're working on research, working closely with research data, we take data privacy and safety very seriously. And these AI training sets, this can be very complicated to ensure that they are private. And what does that mean in the context when you're putting a lot of different people's information into a training algorithm or a training data set? And what does it mean? What information is going to be identifiable versus de-identified? And this is also especially important when we think, for example, about unique conditions that create unique physiologic circumstances for children. Will it be possible for that information to actually be de-identified or not? And thinking about how this is going to interplay with, various legal frameworks, HIPAA, the Common Role, the GDPR in the UK. So thinking there's a lot of different kinds of factors that are going to influence the degree to which this information is protected and private. And then numerous technological considerations. So the transparency of this information, how is things being trained, how are things being tested, how is it that these studies are actually serving the need of a pediatric population, how is that documented in the study protocol, what are the things that can be done to ensure that these technologies are not posing additional harms to pediatric patients specifically versus what harms they may potentially cause to a user of any age. And so really thinking about how we minimize risk means we have to really understand some of the unique technological risks that come from these technologies. And so the application of Accept AI, really, how can we inform the creation of AI and ML data sets and studies that are going to purposefully include pediatric data? How is it that we might embed existing, emerging, and future guidelines and industry standards? So we really see oftentimes that, government regulation and, things are really oftentimes trailing behind these technological advances. And so what can we do from a research ethics perspective to really stay ahead of these issues to the greatest degree possible? How can we use, really do quality work to assess the existing, emerging, and future data sets related to integrity around patient age? And then really assessing outputs from these research projects, from these AI and ML algorithms for age-related bias. I'm very, very proud that our Accept AI proposal has been incorporated into the WHO guidance on the ethics and governance of artificial intelligence for health related to large multimodal models. This is really a great step for us into really helping people in the broader community understand the unique risks to children and that these are not necessarily insurmountable. And now I want to switch gears a little bit to something that, we had not thought about in our Accept AI framework, but I think is very relevant when we're thinking about generally AI and ML systems, is this idea of unlearning. How do we always think of these algorithms, these training algorithms, as they are a learning system. And we talked earlier about a learning system taking in a lot of information. But I want to draw your attention to the concept of unlearning, which just earlier this year, the WMDP, which stands for Weapons of Mass Destruction Proxy, took a data set of questions specifically related to hazardous knowledge. So they thought about biosecurity, cybersecurity, and chemical security. And so biosecurity, for example, would include the CSAM kind of information that we were talking about previously, as well as cybersecurity. And so what they did is they said, how can we use this as a proxy to really evaluate this information in large language models? And how can we work to unlearn this information? And so, again, I have a link to this, to their paper in the resources. I highly recommend looking at it, because what they did is they really worked on how is it that we can actually unlearn malicious content. From these data sets. They use something called CUT as the mechanism for reducing this information. And they actually showed how what they can do is unlearn this malicious content. And one of the reasons why I find this so important is obviously from a public health and safety, from a cybersecurity standpoint. This is incredibly important in and of itself. But I also think the other reason this is important is it is very clear that we have so many outputs from existing AI and ML software that they're perpetuating bias. And so what are ways that actually we can teach systems to unlearn that information, and how will we address that in the future? So I think this group has some really interesting things to offer within this tech space of unlearning this malicious data that I think could have some really positive impacts on unlearning biased healthcare information. Plenty of challenges and limitations to our Accept AI framework. We really started this from the idea of trying to operationalize our ethical principles. We also know that we're sure we missed some important ideas. And so we're actually in the process now of trying to figure out what those are. We're really thrilled that we were able to get this discussion started in the national literature. And we're really looking forward to learning more from more expert groups. And so the way that we're going to be doing that is actually we're currently in the process of building our eDelphi team. We are going to be doing a deep dive into the concepts around Accept AI, and we're going to create a standard, an expert panel, and that's going to include stakeholders like teens, young people, parents, people in the communities that we believe will be impacted. We want people from industry, people who are programmers, technology ethics scholars, and we want people who are experts in pediatric and human development, because these are all things that are quite relevant to the ways that we want to really expand and deepen our understanding of how it is that we can serve a pediatric population most effectively. I never give a talk without sharing a few books, and then we will lead into some opportunity for Q&A. I already referenced earlier Joy Buolamwini's Unmasking AI. If you're on social media, they have a great account called the Algorithmic Justice League, which is fabulous, great place to learn. Meredith Broussard's More Than a Glitch, as well as the ethical algorithm. I think these are all really great sort of introductory resources. If you are feeling in your work like, wow, I really need to learn a little bit more about AI and ML and how it is that it'll interface with your work in a research and research ethics space, I think these are really wonderful ways to sort of dip your toe in without needing to become a programmer. Here's a QR code. So if you didn't manage to get, I'll put the link in the chat again in a moment as well. But here's another way that you can get that. If you're on social media, please feel free to reach out to me there as well. And thanks so much for all of your time.
Oh, thank you so much. That was a really very approachable and excellent overview of some of the really important ethical concerns. We're going to open it up to questions now and comments, and I would invite folks, if you'd like to join us face to face to turn your video on, but certainly no pressure there. But we'd love to hear your questions and comments. I would like to start off just because I know this work was really focused on issues pertaining to pediatrics, which are a really important and uniquely vulnerable population. How would you see this work applying to other populations with kind of special considerations around research inclusion?
Yeah, you know, we chose to focus on kids just because I happen to work with kids, and so that ended up being our first piece that we thought about. But really, when you think about issues related to age, I mean, another unrepresented population is folks who are quite old, folks who are, you know, elders within our communities. They also need to be, you know, not all adults are at the same developmental stage either. And so this concept of like, you know, age, communication, consent and assent, you know, technological difficulties, all of those things actually can be applied to almost any population. Certainly there are going to be unique considerations, kind of the sub questions that you would have under those categories certainly would be different. One of the groups that we've been thinking a lot about are folks who are in that sort of undiagnosed disease categories or rare disease categories. It's hard to know exactly, you know, if you have a disease that there's only 5 people in the world who've ever been diagnosed with it, AI is not necessarily going to be the first step for that population. Now, if you are, however, trying to figure out the connections between a number of different populations, I think there's going to need to be really unique, especially consent, assent, and labeling issues related to rare diseases in particular. And again, this gets to the point as well of like, are you only including typically developing population, or are you including a population that has some sort of developmental difference or some unique characteristic? And if we want to try to study folks who have unique characteristics, how do we ensure that we're doing that in a way that is, you know, ethical and with integrity?
Alyssa, thank you so much for the great presentation. Whilst you're presenting, I was just thinking about something as simple as even reference ranges that we use in the hospitals, and the kind of population we use to identify such reference ranges. I recall, I mean, myself, I went to for an annual checkup where a simple reference range like giving creatinine, which may be dependent on the person's diet, the person's muscle mass or other things. But the way it has been established, it does not take into consideration where the person is coming from, what kind of things are going to even influence this. And we use that to diagnose or push people into categorizations which may not be realistic. So what are some of these ethical considerations that we are trying to use to transform these, even before we start using this data to put into AI and ML to start churning out other things that are not realistic?
Yeah, Isaac, you're making me think quite directly. For example, UNOS just had to redo their entire organ allocation system around kidney disease because of creatinine, exactly what you're just talking about, where GFR, which is a calculation that's made based on, in part, on creatinine, had been racialized inappropriately. And so what that did is they were actually using different reference ranges for people who were Black or African American, rather than for folks who were of other ethnicities. And what that was doing is it was inappropriately harming an entire Black population because they were being diagnosed with severe kidney disease later than folks who were in another population. And so that's actually a really great example of, before AI, we built in a lot of bias into a system, and it has hurt a lot of people. And this is exactly the kind of situation where we have to think. It's a lot to think about when we say, okay, well, if we're going to take this information and we're going to now amplify it into this real black box system where you can't necessarily go back in and see where this information came from, we need to think, what are the biases? Not, is the system biased? How is the system biased? Because all of these systems will contain the bias of the folks who were participating in creating them. And so determining how can we minimize that risk, I think will be really important as we move forward for exactly the kinds of reasons you've brought up.
Yeah, I think that's such an important point. And it makes me think about the accountability piece, right? Which is that nobody who was working on GFR and reference ranges and how to identify, different severities of kidney disease, I don't think that those individuals were intentionally trying to create a biased system. And yet that was the outcome. And so, we're in this period of time now where algorithms are like being developed, left and right, probably many every second. What's the right time frame, right, to look at outcomes and uses, and how do we ensure accountability into the work that's being done both on the development side and in the application for research purposes?
It's really fascinating how there's an assumption that if you ask for ethics help, that an ethicist will tell you what you're doing is bad and you should stop, and don't let change happen because change is always bad. And this is an assumption that is made about interacting and engaging with ethical questions. And of course, part of that is because a lot of times we're looking back rather than necessarily looking forward. And so I think to the degree that we can, in order to embed or encode our ethical values into these systems, it actually requires that the people who are working on these systems from the jump have the wherewithal to say, what don't I know? What haven't I thought of? And that oftentimes requires engagement, interdisciplinary collaboration that a lot of times I think our educational systems and our employment systems do not necessarily promote, encourage, or praise. And so, for example, if you don't have the recognition that, like, I may be encoding racism or pediatric bias or gender-based issues into my code, it's because you don't have a diverse enough team who has thought about these issues. And so how is it that we can promote that interdisciplinary relationship? And as an ethicist, a major hurdle is people are afraid to talk to ethicists oftentimes because they're worried that we're going to tell them you can't do cool things. I don't think that's true, because I also like cool things, but folks are worried about that. That said, I will say, when we initially thought of this project, we thought our audience was academic researchers who were creating these algorithms. And it's been very interesting because immediately after this study was published, we got almost no feedback from people who were actually doing the research in academia. We heard from industry. And our phones rang off the hook for weeks from people who are in industry. They either want to serve populations that include children, or they're like, oh, I didn't realize this was a big issue. And so that's actually, the industry is very eager to have help once they see what it is. And so our interest from researchers, it's fascinating, has actually come quite a bit later. But I would say there's a desire for folks to get good advice, nobody wants to have a terrible PR story about their wonderful startup business that they've poured their heart and soul into. And so if as people who think about research and think about research ethics, if we can be more available and to help create those opportunities, I think there's a lot of good that could be done.
That's a great point. We tend to silo, and I think there's this weird, really uncomfortable relationship. We need industry, but we have to be distanced from them, and there might be lots of hurdles to those kinds of partnerships, and yet kind of recognizing the openness there to thinking about ethical issues and building it into the products that are coming about it is a different kind of partnership that I think is really interesting to think about. Any other questions? Maybe if people are thinking, but I wanted to maybe ask you to say a little bit more about unlearning and how it, because I thought that was just fascinating and so hopeful, the idea that there can be unlearning. And there've been some really interesting ethical conversations about learning healthcare systems, and this whole idea of like, there's data pouring in every second from patients in all of our hospital systems, and we should be using that data for, advancing care and medical knowledge. And there are some interesting questions about consent there and sort of community engagement. That seems to me like a really interesting intersection here as we're talking about how data gets embedded and used and perpetuated and amplified and all that stuff. Do you have any thoughts or comments about that?
Yeah, one of the things that I think a lot of times when we talk about a learning health system, there's oftentimes this idea that like more information is always good and it's always better. But as we talked about with things like GFR, there's a lot of really important and frankly urgent and life-saving information that is wrong that we need to actively unlearn. And I do think that as our electronic medical records evolve and they're already starting to utilize some of these algorithms, and there's a lot of testing going on within organizations like Epic in order to figure out how to potentially use some of these factors. There could be some really effective nudging that could be done within the social groups within medicine. And the other issues that I am eagerly waiting to see is, these large language models, obviously there's important consent and assent reasons that these would need to be evaluated very effectively. There's a lot of biased language that is used in our narratives to describe patients. And many times clinicians, they do not have the insight to recognize the way that things are being written and the ways that it actually is perpetuating bias. It is implanting, logical fallacies that are then negatively impacting patients' diagnostic opportunities and other opportunities. And so I think in as much as this idea of a learning health system sounds very, fancy and sexy or whatever, we also really need to actively think about where are the areas that we need to be unlearning information that has harmed patients for a very long time.
Yes. Yes, absolutely. 100 times yes. Wonderful. Well, thank you again so much, Dr. Burgart, for being with us today and for sharing that information and all of the resources, which I now am going to use all my Audible credits on. Thank you. And thanks everybody for showing up and participating in the conversation.
Thanks so much for having me. This was great.
All right. Take care, everyone.